It's great to have you with us. We are really pleased that you joined us this morning. My name is Alan Mua. I am the current chair of the Washington Alliance for Quality Recovery Residences, or WAQRR, as we call ourselves. Before we dive into today's topic, I want to just be sure you know what WAQRR is and what we're about. We are, to really summarize briefly, our purpose is to increase the quality and the quantity of recovery residences in Washington State. So we work really closely with people who are currently providing recovery residences, as well as folks who are wanting to get into that world, and we equip them to do that. So we do that in three primary ways. First, through our accreditation process. So if you are an operator of recovery residence and you're interested in kind of taking your organization to the next level and being listed on our directory of accredited residences, you can look into that. It's easy to find on our website how to go about doing that. Second thing we do is we advocate. We advocate in Olympia and elsewhere to increase the funding and support and even accountability of recovery residences. So we advocate. And the third thing we do, which today's presentation is a part of, is professional development. So we really want to equip operators of recovery housing to be the best they can possibly be, and by extension then other folks in the community. So we know a lot of people on today's call, you don't work directly in recovery residence setting, but you work with recovery housing, or you refer people, and so you're here because you want to learn more about how things work on the ground, and so you are more than welcome. And so our professional development mission extends beyond just housing providers, but we're really glad to have you here. I want to just give you a caveat about our audience for today. We really have targeted this presentation toward, and a few of our others, really toward providers of recovery housing. But again, there's so much to talk about in today's topic that we know that it's going to be positively impactful of others. But just so you know, we really want to equip people who are on the ground in resident settings to do good work. So the rest of you, if that doesn't exactly fit your category, glad you're here, and hopefully you'll get a lot out of it. We're sure you will. I want to introduce you to two people. First, Justin Cram. Justin is our coordinator of accreditation and professional development. So does a lot of behind the scenes work at WAQRR at just putting these things together. And today will act as kind of our chat monitor. And so if you have questions about just what's being presented and you want to throw them out there, throw them into the chat, and then Justin will be monitoring that, and he'll pose those questions to Beth as she's presenting. And so he has her permission to interject your questions along the way, so it'll make it somewhat interactive. So please use the chat function. We'd love to hear from you. And then finally, I want to introduce our presenter today, who is Beth Fisher Sanders. Beth has become a friend and colleague of ours. She has a lot of things we could say about Beth, but first, she was the founding president of the National Alliance for Recovery Residences. She herself is recovery residence operator, has been in the business for many years, has been in some sort of recovery support since 1987, and currently operates a large housing organization in southern United States, housed primarily in Atlanta and Charlotte. And so she'll talk probably a little bit about her organization, but she is essentially one of us. She runs recovery housing. And so, but beyond that, she is a social worker and a clinician. And so also brings a wealth of knowledge about working with people with a wide variety of challenges, both mental health and substance use disorder. And so is really an ideal person to share this content with us today. So I will turn it over to Beth. I've asked her to provide some time at the end of her presentation for you to ask questions. So you can ask along the way, you can ask at the end. Really want you to stick through the whole thing. And then at the very end, we're going to share with you just a couple of our upcoming events so you know what's coming up. So without any further ado, Beth, thank you so much for joining us today, and we look forward to hearing what you have for us.
Thank you, Alan. I'm excited to be talking to you all in Washington State. I would love to come and do a talk for you sometime in person, but for now, Zoom works just fine for what we're about. And I'm really grateful too that you asked me to do this presentation. Alan asked for, I did this a year ago for you all in Washington, and Alan asked me because nobody else really was doing this, and I told him at the time, I don't know that this topic is anywhere. It's something that I have wanted to write, and I've actually wanted somebody to give it to me, not there, so I wrote it, and I'm grateful for the opportunity to do that. Couple of disclosures. Yes, I am. First of all, I'm a woman in long-term recovery, and that's relevant to me being a recovery residence operator, kind of like what I shared with you about writing this presentation. I got in recovery in 1994. And when I was leaving my treatment center, they said to me, Beth, you live in a basement apartment with one window. You need to go to a halfway house. That's what we were calling them in the mid 90s. There was no place for me to go. There was no place in Atlanta, Georgia, that very few places for women. And I was a social worker, and there was no place that really met me where I was in a professional career, my understanding of recovery. I had been around recovery as an addictions professional for years before I found my own recovery. So it was really, I had no place to go. And so that's ultimately why I started my organization, Hope Recovery Resources, in 1996. I had worked in recovery residences all through the late 80s into the early 1990s in upstate New York. Loved this work because I was able to witness recovery journeys for anywhere between 12 to 24 months, which is what I do now and have done for the last 25 years. Hope was founded in 1996, and actually this month is our 25-year anniversary. And I still am excited. I still can't wait to get out of bed and see what the day brings, because witnessing that journey of recovery, seeing the lights go on for people, it lights me up. And I feel so honored to work and walk with people on their journey. I know I'm preaching to the choir on that one. So let's go ahead and start our topic matter. Another disclosure, though, is that yes, I am a clinician, and I've been a social worker my whole career. And that's relevant in that it gives me some knowledge and authority to talk about this topic matter. It's certainly what I was schooled in, and it gave me a framework to understand what it was I was looking at in my recovery residence, which is a social model, i.e. non-clinical approach, very peer-based, community. We'll talk more about that. But the clinical aspect of understanding what it was that I was looking at, my bias is that most people come to us with some kind of co-occurring issue. Everybody in recovery that I've ever experienced has some kind of trauma. We'll talk a bit about trauma. As far as diagnoses, they're helpful to understand what it is that the resident is operating with, interacting with us in context, gives us a context. But I do not like labels. So I do want to say that the different names of issues that we will go over, they give us understanding, but what I hope they don't do is help us to label people, because I don't think it's fair to people to pigeonhole to just one thing. Everybody's got lots of things. And so these are just understandings and probably a lot of stories that go along with those understandings. So let's get a common framework of understanding. And that really starts with what we call ourselves. Already we've heard some different terms for what we do. I've heard sober house. I think sober house or sober housing is the most common right now, but NAR prefers the term recovery residence. And this is why recovery housing is really a broad spectrum of recovery residences. What recovery housing is the non-clinical component of recovery residences. It's the umbrella term, if you are. And note too that the biggest emphasis in all of that is recovery. And so the best definition I think that's going is what SAMHSA issued for recovery. And that is that it's a process of change through which individuals improve health and wellness, live a self-directed life, and strive to reach their full potential. That's SAMHSA's definition. And under that are 4 dimensions that we certainly address as recovery residence operators. And that's number 1, health, 2, home, 3, purpose, and 4, community. Those are the 4 domains or dimensions that recovery thrives in. Okay, so recovery residence then is more than just a place to live. It's actually a recovery support service. So we provide a service through the community of support that we offer in our recovery housing. And in fact, again, back to SAMHSA, very exciting development that just has emerged is that SAMHSA, the federal arm for behavioral health policy, has issued a statement indicating that recovery residences are an evidence-based practice. Our service as recovery residences is an evidence-based practice. Now, we could do a whole talk on that alone, but suffice it to say that as an evidence-based practice, we have opportunities for policy initiatives, for funding that we didn't have, since we know as an evidence-based practice that what we do works. So while there are lots of different terms, as we see here in sober homes or recovery homes, Oxford houses, even halfway houses, I will use the term recovery residence because that covers the whole spectrum of different kinds of recovery residences. So one of the first things that NAR did when we organized 10 years ago, that's our 10-year anniversary too, is we dispelled that Tower of Babel, those different names, and said we are recovery residences, but there are different types of recovery residences. And we can really delineate it or distill it down to 4 different types of recovery residences. And these different types or levels, as we call them, are meant to be very intuitive, and the descriptions of them are succinct. My experience is that when I walk into different types of recovery residences, you kind of get a feel for what level they are just by looking around, seeing what the resident interaction is, what resident staff interaction is. You can see pretty much right off the bat what they are. You'll be familiar with these types as we describe them. Now, level 1, we had Oxford houses in mind when we were writing this level. I think most people are familiar with the Oxford House system. There are thousands of them worldwide. And the great thing about Oxford House is it's like a McDonald's or an AA meeting. When you walk into one, you're going to have the same way of interacting, expectations, rules, in one to another, whether we're in an Oxford house in Washington State or Texas. They run literally by the book, okay? And that book dictates that the house be about peer recovery support. There is really no oversight for an Oxford house or a level 1, because not all level 1s are Oxford houses, but all Oxford houses are level 1. So with a level 1, the accountability comes in the peer-based community. And that community runs the recovery residence in a democratically based way. Everybody has responsibility for the operation of the house. Now, for level 2, we're going to have more enhancement of staff. So and that staff generally looks like a senior resident or a house manager. Those are the two most prevalent ways that we see staff, and that staff provides accountability and enforces the standards or the rules of that house. Now, we still have the strong peer-based element. And for a level 2, the expectation generally is around meetings and productive activity, whether that is work or volunteering. But folks that go to a level 2 are stable physically and psychologically, and they're self-motivated. They're generally invested in recovery. So level 2 is about same things level 1's about with the peer accountability, but there's a little extra layer of structure found in more rules, more staffing. And then we have level 3. This is actually what my organization has evolved to be, primarily because we serve a higher acuity co-occurring population, which required more staffing. So the more staffing and the more structure I provided, i.e. through life skill-based curriculum, my residents, because they over time evolved to be a higher acuity resident, maybe they were coming from detox or even a psychiatric facility. And that happened very organically because people knew that I was a social worker and I could manage a higher acuity client or resident. So over time, my level 2 became a level 3 because I evolved to have more staff and a life skill curriculum or life skill development emphasis. My demographic became broader as well. We absolutely always serve substance use disorder, but we were able to assess and accept into the organization co-occurring populations with more complex needs. And that really is a succinct way to describe a level 3. It is just short sometimes of being a licensable treatment. We are not, nor do we want to be. We don't purposely adhere to a social model, non-clinical. However, I will share in full disclosure that having that clinical background can be helpful. I've seen level 3s utilize a similar approach, even if they don't have a clinical person in their system. They might align with somebody with that background to kind of supervise their staff. And then with level 4, and under the NAR umbrella, we're really talking about a recovery residence that is clinical, has a clinical component underneath the umbrella. In all 50 states, it is a licensable residence. Okay, so it has to still have that social model, peer community factor to it. The community is a key component in all 4 levels. And when I talk about social model, I am talking about community and all of the things that we do to develop community. We'll talk about that in this next slide, that really that is the foundational element of all of the residences. And then as we move to level 3, we're really getting into that life skill emphasis. And finally, in 4 only, we have the clinical aspect, which of course has to be licensed through the state in any state of the United States that we operate in. So the last thing I want to say, because again, this component is one that we could do a whole presentation on by itself, but one level is not better than another. As we'll get to later in the presentation, that it's important to understand the full continuum of care. And in Washington, the Washington affiliate, I believe, encompasses all of these levels that we've gone over. It's helpful in the affiliate to understand what level your counterparts, your peers in the affiliate operate in, so that when you need that higher or lower level of care to step your residents into to facilitate them, that you have a quality provider that you can refer to. One serves different needs. One is not better than the other by any stretch. So let's look at where we are today. I get excited about mental health. I prefer mental health. Behavioral health is more of a clinical term, but it is the going term at SAMHSA right now. So we'll use it for argument's sake. What I like is that through under SAMHSA and administration changes, all of that, we are seeing needed change in our industry overall with behavioral health, that up until this point, substance use disorder operated over here. And then we had mental health issues such as depression, bipolar, anything that falls under mental health over here. And never did they meet. Oh, and then there's things like eating disorder, and we'll talk about the different processed addictions over there. And never did they intersect. But I'll tell you, in all my years of work and practice, I have never seen anybody with just one thing. So to keep them separate, for me, is like pinching one end of the balloon. Well, that other end of the balloon is going to get bigger. So what's happening is that we're de-siloing through SAMHSA's leadership, and it needed to happen, everything under a behavioral health umbrella. And that really helps us as providers on the ground to more fluidly link services, especially as operators, that we can work fully in that recovery oriented system of care. Did want to touch, as we were talking about the components of recovery, I really like this this flyer that SAMHSA issued, because it sums up to me what we do as recovery residence providers and what the standard that we adhere to and what you do as you certify addresses. And these components you'll recognize, because they tend to be the core principles in our standard, our 31 national standards. The first is about hope, that recovery helps give hope, that recovery, the way SAMHSA asks us to do it, and our standard, is person-driven, not clinician-driven, person-driven, that the individual gets to determine their pathway, and that there are many pathways to recovery, that the 12 steps work great for some, but not great for others. And that our job as helpers is to assist the individual in finding what works for them. And we understand that there are many factors to recovery, to that recipe for recovery, that is biological, psychological, social, that social aspect we work really hard at in recovery residences, and spiritual too. And let's not forget about the peer-based element, that peer support, that relational support is just so vital to recovery. Relationships are everything. And then the standard helps us and guides us in creating the elements of a healthy culture. And that's one of the things I really appreciate about that social model based standard, is that it really gives us direction as operators on how to create healthy culture. And it addresses trauma, because trauma, as we'll talk about again, is the cornerstone of many, if not most, behavioral health issues. And that recovery is strengths-based and emphasizes responsibility for healing in the individual, that I have the ability to find healing for me. I don't have to depend on that person, therapist, sponsor, anybody to deliver that for me. They can facilitate it, but they don't give it to me. I find that within myself. I'm responsible for finding that in myself. And that we treat everybody with respect. That respect is also a cornerstone. So these 10 principles, I think, give a lot of light to the core elements of recovery, and a very insightful summary of what recovery is all about and what we deliver in recovery residences and as affiliates through the standard. So the other change that has happened is that we have this middle ground now that we didn't have before, that we can intersect the circles, and we are in our day-to-day operations. We all are. When we have stressful days where we don't quite know what to do, chances are it's because we've been working in this middle area for most of the day, that we've not only been dealing with the substance use issues, and many of us are in it because we have it and want to give back. So we have an appreciation and an understanding and a comfort level that maybe we don't have as much with the mental health issues. So that can be anxiety provoking, it can be stressful. And so the co-occurring issues are important to understand for ourselves. And then when we don't address mental health issues, it can make that community aspect of what we do so difficult. That the stress, the anxiety, the maybe difficulty sleeping because I'm not medicated properly, make the community culture difficult. They also increase the risk for things like return to use relapse or anything else that's self-harming. So it's important that we have this understanding of that right side of the circle, the mental health issues, and how it intersects with the substance use disorder. And it's difficult too, because oftentimes we don't know which came first, the chicken or the egg, with the co-occurring. And I want to say to you that my experience is it really doesn't matter. What matters is that we understand that both play a part in the recovery, because we focus on the recovery of the individual. So what are we talking about when we say co-occurring? Well, it used to be called, when I started out in the field, dual diagnosis. It's not really an accurate definition anymore either as far as language goes, because there can be so many different issues going on with an individual. So it's really any substance use disorder coupled with something else, and that something else can look like a mood disorder or a issue with personality or post-traumatic stress disorder or schizophrenia. So all of those things can be part and parcel with what we look at. So co-occurring, definitely, it's way more than that these days. So what are the different types of issues that we might encounter? Well, the first is really about, and I think we see this with I'd say with most of our residents, because if we're putting down the substance in early recovery, we've got this big gaping hole to fill. And so we'll see behaviors that emerge. Now, what makes them addiction? Well, if you operate with a understanding of addiction, we know that addiction is a compulsion that is perpetuated despite negative consequences. That's the most easily understandable definition for me: compulsion despite negative consequences. So a process addiction, well, these are very common issues that we see. A lot of them we have standards around, don't we? Gambling is a very common standard to say we don't allow gambling in the house because it's used as a way to self-medicate. And along that same line of thinking is gaming. I see a lot of gaming issues, and not to be sexist, but quite honestly, I see gaming as a huge issue in my men's residences. I do operate a lot of residences for both men and women, and in every single residence of my men's community, there is a game console of some kind. I don't have, well, maybe I have one, and have had one over the years, but I have very few in my women's residences. So we do see a lot of gaming in my anecdotal experience with the men's communities particularly. It's a way that they connect, I think. And then there's relationship issues, big one. I don't have to say a lot about that because we all understand and experience it, that if I'm not using substances, then my next go-to, and this is across the board, is likely to be a relationship. But again, when I cross over into addiction is when I begin to have negative a compulsion towards that, despite the consequences. Shopping, very big issue, especially these days. I'm seeing a lot of online shopping, and we've had to, in this era of COVID, we've actually had to step in as staff and set some guidelines around the online shopping. And then there are compulsions regarding food. And this can manifest into full-blown eating disorder, but food, sugars are often used to fill that void. So to understand about process addictions and when we cross over the line into an addictive pattern, but invariably we're going to see seeds of this emerging with most of our, if not all of our residents, some kind of seedling for a process addiction. And the guidelines, that accountability and support that we provide as operators can keep that seedling from growing into a full-blown addiction with issues. It can help with that. It doesn't keep, it can help. So then we have the eating and body issues that can emerge as process addictions. And I do think of eating disorder or disordered eating. There are lots of different categories. So what we're talking about, so they really can be summed up into these 6, and we'll just touch on these so we understand, have that common language of what we're talking about. That an eating disorder, the way to think about eating disorder is it's a disturbance in eating behavior and the related thoughts and emotions. So it's a severe disturbance is when it crosses over into an eating disorder. Now, a disordered eating pattern oftentimes can be the prelude to it. It is its own issue in its own right. Disordered eating is an abnormal eating behavior that occurs on a regular basis. And it's generally a way to cope with a negative emotion. It's a coping mechanism, is disordered eating. Okay. Body dysmorphia, very common in early recovery, is an obsessive, in both genders, by the way, is the obsessive focus on a perceived flaw in appearance. I see this often in my men's community with a desire to work out compulsively, which leads to the compulsive exercise component, and that is exercise that is used to cope with anxiety compulsively. So one can lead to the other as we go around the triangle or the rectangle here. Bulimia is an obsessive desire to lose weight by purging after typically overeating. And then on the other end of that spectrum is anorexia. Anorexia is the obsessive desire to lose weight, and we restrict food or refuse to eat outright. So those are just working understandings of what we could see and do see, sometimes as seedlings, sometimes as full-on issues in our residences. And then we have mood disorders. And when we think about mood disorders, depression, I think we're all familiar with depression and what that looks like. It can start out by looking like dysthymia. I don't want to get out of bed. It's mild form of depression is what dysthymia is. We might see issues with eating or sleeping. And then it can emerge to a full-on depression. And when we know it's a depression, is that our daily life activities are really interrupted over an extended period of time. And that can be more than, according to DSM-4, more than 2 weeks. So you're seeing a pattern of loss of interest in usual daily activities, ongoing feelings of sadness or hopelessness, and issues with eating, sleeping too, that have emerged to be a pattern. And then lastly, in the mood disorder category is bipolar, and that's a combination of the depression and mania. And so it's basically bipolar is an extreme mood fluctuation. Now, it can look, all of these things that I'm talking about, including the next slides coming up, The problem is that it can look like early recovery, right? When we are coming off of alcohol and drugs, we're not feeling so great. And that can look like dysthymia or depression. And then we might hit a patch where I have a euphoria because I'm in recovery. Does that mean that I'm bipolar? It does not. The key with all of the issues that I'm referencing is that you have that factor of time in them. So you're seeing patterns emerge over time. So these are bookmarks. What this presentation is really about is giving you a language and a bookmark to reference if you begin to see patterns emerging in the individuals in your community.
Just to really quickly interject, we did have a question that was posed,
Sure.
which was asking for an example of a difference between eating disorders and disordered eating, because the individual is still a little fuzzy on the difference.
Absolutely. So let me go back to that slide. So when we're talking about a disordered eating pattern, typically, not always, but often, disordered eating prefaces an eating disorder. And in my experience, anecdotally, for the need to know for the recovery residence operator is we will see disordered eating a lot more than we will see an eating disorder emerge. So disordered eating is any unhealthy, abnormal eating behavior that occurs on a regular basis. So what that might look like is I only eat one time a day because I think that and then this gets into the dysmorphia. They can link up together. I think that I am too heavy or I don't want to gain weight. I have anxiety, or I'm using food to medicate, which also happens in an eating disorder. But it's not an eating disorder because we don't have the level of severity, the disturbance in the eating pattern. Okay. So a disordered eating, I guess simply and succinctly, is a milder eating disorder. It's an emerging eating disorder. I hope that helps. The eating disorder is a severe disturbance, and that is those two words are what characterize an eating disorder, a severe disturbance in eating disorder. And eating disorders are anorexia, bulimia. Those are the common eating disorders. All right. And please, I will have my email and contact information at the end of this presentation. If you have questions, feel free to reach out and we'll have a question time at the end. Anxiety disorders are common too in our recovery residences. And here is just a very simple, succinct slide of the different kinds of anxiety disorders that we can see. The generalized anxiety is I'm worried a lot, maybe obsessively worried, thoughts about things. I just have a high level of anxiety that makes it difficult for me to relax. I'm in a chronic state of stress. Panic disorder is when it becomes overwhelming, that I have a hard time functioning because that fear and anxiety in me is just debilitating, that it's hard for me to make it out the door. And then post-traumatic disorder is a result of a stressful experience that can be triggered. post-traumatic disorders can fluctuate in how they reveal themselves. The 1 minute a resident may look okay and be stable, and then something can trigger them within the community and they become very anxious, fearful, stressed. And that is typically a result of some traumatic incident. Obsessive compulsive disorder is about behavior, and it results from obsessive thoughts, intrusive thoughts, and that manifests in behavior. So I'm using my behaviors to manage my anxiety. Maybe it looks like excessive cleaning, or in this age of COVID, we've seen a lot of this particular aspect of anxiety emerge, where the just constant cleaning, or I might be afraid to go outside, or if I do go outside, I've got to go through a lot of rituals to be safe, to be clean, all based in anxiety. But with the OCD, it manifests in behaviors that I can't stop or control. Social anxiety, another thing too with the COVID, is that we're afraid to interact in public, that there's anxiety in interpersonal interaction of any kind, and that has clear implications for what we do working in community as recovery residents, operators. And then the phobias are obsessive, strong fears for things or situations. So it's an irrational fear of a thing or a situation. A common one that we've all heard about is arachnophobia, which is fear of spiders. Agoraphobia, going outside. I'm fearful of the outside. There are literally hundreds of different types of phobias, but it's an anxiety that manifests in one specific context or way, which has behavioral implications. And all of these things, folks, I'm not doing justice. This is thumbnail sketches all the way, just to have that outline and framework that we can operate in. Now, a thought disorder is not as common in my experience in a recovery residence, though we will see it. And a thought disorder is a mental health condition that impacts a person's beliefs, their thoughts, the way they look at the world, and it alters the way the person thinks about the world, and therein impacts the way they relate with people, situations, etc. So it can look like paranoia, and it can manifest as kind of a delusional thought, maybe even a hallucination. Okay, and again, we can see we might have a pause for concern, because especially if we have people in our homes that are fresh out of detox, for instance, it might look like this in the beginning, especially the paranoia or the delusional kind of thinking. But it might not be a thought disorder. It might be just a post-acute withdrawal experience that the individual has happened. Again, with thought disorder, like the other mental health issues, it really is about time. Are we seeing a pattern of this over time? Now, sometimes we will see people, when we talk about spectrum, people that are on the spectrum, we are talking about autism, spectrum disorders. And autism ASD is about interpersonal difficulties, that there is a barrier chemically, interpersonally, that makes it difficult for me to engage and interact with people. So that looks like restricted interests. It can be repetitive behavior or behavioral tics like hand wringing or objects that I'm focused on that I absolutely have to have. And, you know, sometimes with people who are on the spectrum, and most often what we will see as recovery residence operators is more mild ASD issues, and that would qualify for Asperger's as a mild autism spectrum disorder. And we might see it in fixation on my vape. I've seen the vape as a way to have something in my hands, and also can bleed over into anxiety as well. But when you know it could be part of a ASD is that interpersonal issue. Difficulty with eye contact is another telltale. And then we have personality disorders. And a personality disorder, there's lots of things to say about personality disorders and lots of different types of personality disorders. And I hesitated even to put this on the presentation because I'll share with you a pet peeve that I have. And that is that I have been in a lot of staff meetings, particularly clinical staff meetings, i.e. in a treatment scenario, where a woman will be dismissed because she's a borderline, or a man will be dismissed because they're a narcissist. And then what they're talking about are personality disorders. So I'm distilling that person down to a diagnosis. And I really want to caution you and strongly encourage you to be mindful about that we as peer supporters, as helpers, look at the whole person. The personality disorder is it is important to know and understand about, because not understanding it, and we can see that it can wreak havoc on the community. That a personality disorder ultimately is the way a person engages and views their world and engages with the people in it. So the different types are the different ways that we have our framework of the world, which therein guides our behavior. Okay, so for a person with a borderline personality disorder, borderline, that particular diagnosis was, I think it first came out in 1950s, and it was short for borderline schizophrenic because it looked at times like that person was not fully functioning in the real the world as others in society were viewing it. They had their own view of reality that didn't match up with the environment. So with borderline issues, the individual tends to operate in all or nothing extremes. And many of these personality disorders, you can describe that it's an extreme way of engaging with the world. So I see we've got, and I knew this would happen with the personality part of it, I've got several questions coming in. So Justin, is this a good time to pause and take those questions?
Yeah, so let's see the questions that we have. Well, first we have a comment from Alan that said, so important not to reduce people to diagnosis, especially since most of us aren't qualified to make a diagnosis to begin with.
Thank you for that, Alan. I appreciate that.
And then we had a comment that said, good point.
Great, great. Yes. I've been asked over time when I've consulted with recovery residents is if they need to have a DSM-4 is the latest diagnostic manual. And you don't. I'd encourage you not to. It's really confusing, the manual. And the thing is, they're on their 4th edition. They're always changing it. Now, it can be helpful. This slide, a lot of the summary comes from the different names of things, but I will say that what I am saying to you is really my experience. This is my translation with and for you as fellow operators of how this is relevant to our daily operations. So we are not qualified generally to make, and I'm not either, not at my level of care. It's not appropriate for me to make a diagnosis. What I do often in collaboration with my staff is to make a guess. And then if we feel like we're looking at this, that's when we refer out, because that individual needs collaboration in the community through the healthcare resources to manage the issues which we see evidenced in our community. And we'll talk a lot more about that later in the presentation. Is that the point you wanted me to get to, Alan?
Yeah, I just wanted to reiterate that's so important. And I know I said it in the chat, but I just can't stress enough. I think the temptation in watching or just in these discussions is, oh, I've got so-and-so figured out. That's what it is. The question then is, so what, right? So what do we do with that? And I think what you just said is so vitally important. Well, the so what is, okay, maybe we have a hunch, or we can, and guess is a great word. Let's not glorify it any more than that, right? But to say, okay, so what kind of support, if there is something like this going on with a person who maybe has never had support for that disorder before, how do we help that person maybe get in touch with that so that they can get what they could need to live life with that particular situation, whatever that might be. And just personally speaking, as a person with a disability myself, I just know that there are just things that little tricks that someone can help you learn to cope with whatever it is that you're dealing with, and it just makes life better. So what an amazing thing presence we could be in the lives of our folks by connecting them with a resource that would actually help them do this. Anyway, I'm preaching, but thank you so much for really just calling that out. I appreciate that.
No, I really appreciate you underscoring that point, because that's a key point. And this is the last bit that we'll touch on, and this is also something we don't see a lot of. The dissociative disorder is a trauma response, and because it's important to know that this could be something we see, and it's characterized by missing gaps of time that I feel that I can't track a conversation always, that I don't feel connected to my own body. And we see this occasionally, sometimes, with individuals that have experienced significant sexual trauma, particularly. So just something to know and understand. It is often characterized by missing gaps of time, high levels and fluctuating levels of depression, anxiety, and even suicidality, not uncommonly suicidality. So I know we're getting short on time, so I really want to move on to the application part of the presentation. And this is a really important point that I want to emphasize, is this staying in our lane, that the most important interaction we have with those we serve is the first one. And that first interaction really is in determining, are we the best fit for the individual? And the way we determine that is by doing a good assessment in the beginning. So what are the things that we want to assess and see about to make sure that we are a fit? And this goes back to what we were talking about regarding levels. So all of these points also relate to the levels. For instance, with stability, are they things like, are they physically stable, and their motivation? Well, if I'm not particularly stable physically and I don't have a strong motivation for recovery, it's not appropriate for me to transition to a level 2 or 1 from a detox, is it? So that's one of the points I want to make sure that they're appropriate. Are they ready for the type of structure and staffing that I'm offering in my recovery residence? Are they able to manage their own impulses, self-regulate? Another factor to consider is their medications. Now, people in early recovery, the assessment piece can be tricky because folks that are new to recovery are not always the best historians or describers of what their issues are. So I really recommend, when you're doing assessment, don't just get the individual. Try and get collateral input on that assessment, the referral source if they're coming from another facility. Family can be very helpful. And another factor is medications. They might not know what their diagnosis, what their issues are, but their medications that they're taking can be an indicator of what the issue is, that their co-occurring issue is. You have to understand too the medications to avoid an abuse potential, both with the individual and with the community at large. So a thorough history is not only helpful, it's essential. And then, what level of functioning am I operating in right now? Do I need a lot of help and structure? I find that a lot of the young adults that are brand new to recovery are not particularly functional as far as basic life skills. They benefit from that higher level of support, staffing, structure, and rules to help them improve their level of functioning. Will they be able to get employment? Are they in a place where they can, or go to school, or do something productive with their day, to volunteer? Do they need ongoing treatment or therapy with their day? Important to find out about. Another clue that can be a piece of detective work too is violence. That it's very important. When many of our residents will indicate that there has been violence in their history. That does not preclude them, by the way, from being a part of your recovery residence. A key factor is to understand if there were substances involved. Were they under the influence of something, or related to the psychiatric, psychological issues? Were they unmedicated? Sometimes a violent episode can occur because I was not properly medicated or not medicated at all. And then how do they feel about it is an indicator. So, but I guess I'm saying here, don't let violence scare you off, or it's not necessarily an indicator of a co-occurring issue, but it can be, and we need to understand it. Suicidality and self-harm is an important part of an assessment. Any assessment for any level of care or level of recovery residence. When was the last incident of suicidality? And what is the history of self-harm? And bear in mind that not all self-harm is suicidal in nature. Self-harming can be a form of coping, and we need to understand that. And then the history of the suicide attempt, was it intentional? Was it under the influence? What were the dynamics of all of that? And do they have any of those thoughts right now? And again, back to levels of support in the recovery residence spectrum, the higher the recovery residence level, the more resources may be available to serve the more complex psychiatric needs. We do really need to understand at all levels the trauma history, what that trauma history was. They might not understand it, especially in early recovery. But when we're talking about trauma, two important points to note. One is that trauma experts indicate that at least 90%, and I'd even say higher than that, 90% of those we serve in our recovery residences with substance use disorder have some traumatic incident in their history. We need to understand that. And the 3 E's of trauma are the events, the experiences, and then what are the effects of that trauma. And trauma, the best definition is what I have posted here. And so what we know from SAMHSA is that 61% generally, and this is anybody, 61% of men and 51% in our country have a trauma experience of some kind. There's a lot of good things written about trauma. One of my very favorite books for understanding is Body Keeps the Score by Bessel van der Valk. And then the ACE scale can be very helpful in determining trauma. And I've even seen, I've added and a general assessment instrument that NAR wrote for just covering the basics that we would want to have in an assessment. But I've also seen some add that ACE scale, which is the traumatic experiences, adverse childhood experiences, because trauma happens in childhood most of the time. And that can help us understand that history as well. And it can be a part of this assessment instrument. Very quickly, I know we're short on time, the management issues that our residents, because of co-occurring issues, trauma issues, we can see impact in sleep, diet, hygiene, and exercise, or lack thereof, that residents with untreated behavioral health issues need help in all of these areas. And so again, the level of recovery residence that you are indicates how much help you give in these areas. At level 2 means less hands-on help than at a level 4 in helping the resident with activities of daily living. Med management is another biggie for daily operations, and it is something that we have to do if we are accepting a identified co-occurring population. Are they able, we need to have an understanding in that assessment instrument of, are they able to maintain their own medication, self-administer, and are they able to come and get it at the office or however you deliver that? And if staff is involved, and the oversight of the medication, that according to the NAR standard, must be documented. And all levels of recovery residence is just a reminder that all affiliates need to have a medication policy and procedure in writing. Trauma considerations are, remember that the emotional and physical safety of your community is #1 priority. It's what we do, that cultural issue we were alluding to. And this is a biggie, and especially now in COVID times, if you want to give a hug, ask that resident before. Staying fully clothed in the common areas is very important, because not being clothed can be triggering for people with high trauma histories. And then the curfew check protocols, consider them, consider how you do them. You know, many operators will come in the bedroom and maybe I might even have a light. Talk about that in your community. Talk about that with the resident coming in. Talk to them about how you do curfew checks, and understand that you might need to make some adjustments to how you do that, because coming in a bedroom at night, dark, for somebody who has experienced sexual trauma can be extremely triggering. And then think about the private room versus the shared. And it's good to and I think it's just respectful to always knock before entering a room or residence, and always insist on notice before anybody from outside the community comes into the recovery residence. Again, with the pandemic, this is an important procedure too. For us as helpers to be mindful of our body language and our vocal tone and the words that we use too. If I'm going to confront you, that can be perceived as a threat. So language is important. The decibel of our voice, all of those things are important to be mindful of. And then obviously I have a bias about this, but I am a big believer in the benefits of a collateral psychotherapy experience outside the recovery residence. And once the individual is stable physically, from substance use disorder, psychologically from other issues, the psychotherapy can help to the stabilization process. And that we as helpers can connect to the coping resources, which can be holistic and helpful too, the self-help groups, the meditation, yoga, etc. Interpersonal, to be mindful of trust, that is foundational. And then a big healing element is time, that time and recovery is in itself time, trust, community, a safe community are healing balms for individuals with all these issues. And also consistent, enforce clear guidelines, that there's a lot of safety created when my guidelines are adhered to, promoted, that they're consistent for everybody and every time. Community and belonging in that community can have such a healing effect. I know you all see that too. And to be aware of those family interactions, that we need to have knowledge of what family impacts and that interaction can have on the individuals we serve, because family can be a big stressor and a trigger for our residents. Suicidality, don't be afraid to ask the question. That's the main point of this. Are you thinking about hurting yourself? Are you thinking about suicide? It happens in early recovery, Ask them for how strong that thought is. Do you have a plan? And this can be a whole training in itself. I've included a contract if you experience it, because this tends to happen late at night, right? So a contract can be helpful in being a guide for, do I need to take the resident to the hospital tonight, or can they adhere to this contract and be safe for the night? And then other thoughts are to use your recovery-oriented system of care, use all the tools that you have within your circle of support, the referral source, your families, therapists, counselors, your life skill training organizations. And then staff training, just like what we're doing right now, is essential. Ongoing CEU, supervision and consultation, to stay open and be timely with dealing with issues and communicating with your staff. I know that having apps, and we're constantly on the phone, on the apps with each other. My team uses GroupMe with each other to communicate in the moment what we're seeing. For us, it's more efficient than just regular texting. Be aware that time is a great healer, that co-occurring issues take more time and benefit more from being longer in community, and individual time given is key as well. And then lastly, don't forget to have a laugh sometimes, and that sometimes these are serious things that we've been talking about, but sometimes it can be kind of funny how they manifest. And let your resident guide you and when it is funny, but track with them to find the joy in the healing, in the interaction, in the community. Find the joy in it. And to sometimes, because these are heavy issues, they can wear on us and it can be stressful. But we are not, recovery residences, y'all, are not treatment light. We're not treatment at all. Is it rehabilitative? Yes. Is it healing? Absolutely. I think being in a recovery residence is the most healing way we can achieve recovery in the context of community, intentionally using community as medicine, as a healing element for all the issues that we've talked about. Well, the best way as helpers to engage in that environment is by simply being ourselves. And with that, I will end. And if anybody has any questions or comments, I'd love to dialogue with you.
Thanks so much. Been so helpful, Beth. And we will wait for, it looks like there's some stuff in the chat, so I'll let either you can read them or Justin can along the way. But I've always got material. So what do we have there, Justin?
We have a comment that says, yes, humor is helpful. This was very good.
All right. Great.
With exclamation points.
Yeah.
Thank you.
Those last couple slides, I just we could again spend hours just talking about the significance of sort of what you do and what you look for. I was particularly struck by the slide that just talked about those. I don't remember what you titled them, but the indicators, right? So the patterns that are disruptive, sleep, just activity level, those kinds of things. The things that essentially looking for changes can be super indicative that something's going on. And as you say, we may not be able to, even at a lower level of care especially, much we may be able to do to treat something like that, but to notice it might be a pathway for somebody, huh? I mean, that could be at least saying, wow, something has changed here, or something looks different or feels different, or it just feels outside of the norm for this person. So what do you do at that point? So you see something that's different. Any thoughts, Beth, on what you would do if you see something that's changed seemingly significantly in a resident?
So I think it's really about using that established relationship. To me, that's our greatest tool, is
Yeah.
the rapport and relationship with a resident. And when we have it, it's natural then, isn't it, to just sit down and say, hey, I've noticed this. Can you talk to me about what's going on? And they're going to give you one of two responses. It's, no, I didn't realize that was happening. Or, yeah, I am struggling. I'm just not sleeping, or I just feel awful and depressed. And then depending on that response, invariably you're going to be led to go into your ROSC to seek support services. It's just knowing what's the best first place to start.
And you have sent us a couple documents. I don't want to forget this, but you sent us a couple documents that we're going to send out to participants. Remind me what those are. One in particular was your, I think we've got slides, right? But then the intake, was it your
Yes,
intake
so
document?
the two templates I sent you in addition to the slides are the assessment instrument. Just compare it to your own. And yours might have way more than what I've sent, or there might be a couple things that give you an aha, I need to put in my own. And the second was a real game changer for me when I found this contract as a safety contract. So when you have that resident that at your curfew check is not doing well, expressing some thoughts or fleeting thoughts of hurting themselves, even maybe thinking about suicide, as you talk with them, are they able to agree to that safety contract and be safe for the night or not? That, just working with the safety contract is an hour in itself.
Yeah,
but
for
it
sure.
really is about, can they agree to this truthfully? Can they be safe tonight?
Those are great tools. When we looked at this last year, we took a look at even our application to say, is there more that we need to ask? We want to be appropriate and fair in how we do that, but the deeper we get into relationship with a resident, the more it's helpful for us to know. And I think way back at the beginning, the reason why you included levels of care, at least what I interpreted, it was just that it's vitally important in some of these things that we assess whether we have what a person needs, right? Either too much or too little, even. And so, boy, that just feels just vitally important, that these kinds of things are what you would use in making that kind of assessment. And I think everyone who's been in this world for long enough have maybe taken on a resident who maybe we shouldn't have, because they just had too much going on. And the reality on the ground is, because there's not enough recovery there aren't enough recovery residences of any kind out there, it may be in our particular area, we take on somebody because there's not going to be another option for that person.
That's right.
But the challenge is, boy, we don't have what they need in the level of support. And so those are hard lessons to learn. Yeah. Justin, I'm going to ask you Beth, if you could take down your slide for a second. Justin's going to put one up for us just in closing, but if there are any other questions, we can read those out as well. If you want to go into the chat, Beth, you can do that while Justin's working on just getting up our announcement slide. But anything else that you'd like to respond to?
No, I think we got to everybody.
Okay, great. Well, Beth, we're just so incredibly thankful for your time and the effort that you put into it. I'm glad that we were the impetus for you creating this presentation.
Oh, thank you for that.
It was really, really useful to us, and I'm glad we got a couple runs out of it, and I'm sure there will be more. And for us, they're just great conversation starters and continuers. So Beth, thanks again. I want to close our time together this morning by just showing our participants what's coming up. You can see here on the screen, but essentially we have 2 more webinars on the calendar, and we kind of run on the state fiscal year. It's just sort of how we've organized ourselves. But we will be announcing more monthly webinars into the summer and beyond before too long. But then these 2 all-day events, I want to make you aware of, everybody, that one of them is our kind of our Recovery Residences 101 event. So where from 10 to 3 on that May date, we're gonna talk about levels of care in a little more depth. We're gonna talk about just some of the kind of key issues, things that we work with. So if you're new to the recovery residence world, either as an operator yourself, or you're thinking of starting something, or you're in an agency and you just kind of want to know more about our world, we'd love for you to join us that day. And then in June, we're doing, we just switched it to virtual. We thought we would finish up our big virtual stuff in June. We've just made that switch, so you can now register online to join us for the webinar version of our training for accreditation team members. So we need people, as we're accrediting more operators, we need people to join our teams and help us in that process. So if you're interested in doing that, that June date would be a requirement for you before you came on board. So would love to have you join that event as well. If you have any questions about any of those, please feel free to email us. Our website is WAQRR, WAQRR.org, and we'd love to hear from you. Again, Beth, thanks a million. Anything from Beth or Justin you want to say in conclusion here today?
Thank you for the opportunity. Be well.
All right, take care all, and we'll see you next month.